Welcome to the first episode of Addiction Doc, a podcast where we speak the simple truth about a much misrepresented and misunderstood field of medicine. Our host is Dr. Eric Troyer, a board-certified specialist in the field. If you or anyone you love is struggling with this terrible disease, this podcast is for you. Dr. Troyer is currently practicing in Landis, North Carolina, and can be reached at 704-855-2101. Or you can check out their website at troyermed.com. Let's step into this discussion and see what we can learn from Dr. Troyer himself. Okay, so Eric, what's your goal?
My goal is to reach not only people who are battling with addiction, which I'm not going to use a lot of, the word addiction, just because it has a stigma associated with it. Because if you go pretty much anywhere, I mean, if you go to jail and talk to a child molester, he's going to say, well, at least I'm not like that guy over there who's a drug addict. You go to churches, you hear, oh, we need to reach out to all the dregs of society, like the drug addicts. It's just always, they seem, for some reason, despite they haven't necessarily gone out and killed anybody or done anything that the other people have done, always seem to be considered at the bottom of society. So, with that being said, I'm probably going to use the term people or persons or whatever with substance use disorder, or SUD. That's probably just going to go ahead and abbreviate that to SUD, which is substance use disorder, which includes pretty much all the people who are addicted to different things. Not necessarily the behavioral ones like gambling and pornography and video games and shopping and all of that good stuff, but more the chemical ones like alcohol and, of course, the opiates. But that's probably the term I'm going to use. But not only to them, but because for every one person with SUD, there are at least a handful of people, family members, friends, acquaintances, co-workers, that are impacted by their addiction. So I'm going to try to target a good bit of our talks toward them as well. A lot of the podcasts that I've listened to, I'll talk about inhibitory downregulation of postsynaptic neurotransmitter levels and presynaptic neurons and all this other stuff.
And you wonder who's smoking the crack.
And yeah. So we're going to try to, I won't say dumb it down, but make it much more graspable as far as what the causes are. Not only chemically, where in the brain this all happens, but also behaviorally, our life experiences. And we're going to do that through, we're going to have a little fun. I mean, addiction is definitely a serious subject, and one person dies every 9 minutes from it. You can't get much more serious than that. But at the same time, I believe that kind of tackling things from different areas that probably have not been done before may be very useful in helping people get the help they need, or at least to the help that they need to overcome their addiction. So that's kind of where we're going to focus. We're going to also give updates on what's going on in the community. Each time we have an episode, I'm going to kind of give an update on what's been happening and the drug screen results that we get, the legitimate ones anyway. We do still have people trying to fake us out with the fake urine, bringing in grandma's pee and all of that stuff. But fortunately, the state of the art has developed to the point where we can tell that, and then we don't get to trust the person anymore. We have to trust the drug screens, and there have to be a whole lot more of them, which is something I tell my patients from the very first time they come in to see me. In addition, we're going to do that by talking to people such as yourself who've done counseling, we thought we could try to get a pharmacist in here too, because
Oh, that would be really good.
for some reason, buprenorphine is being limited at the pharmacies. I went to a medical conference about a year and a half ago, and big question going around is, do your patients have trouble getting this medication filled? And at the time, I said no, because it hadn't hit here yet, but now it's hit here. I spoke with a pharmacist yesterday who had been told by the powers that be. I tried to nail that down a little bit as far as who those powers are, but I'm fairly sure I know where ultimately it stems from, that they couldn't fill buprenorphine for an entire month now, no form of it, because the powers that be, they had used their quota, and now they were on prescription for a month, and the pharmacist told me point blank that she's probably just not going to bother billing anymore. Now, that's not been the case with oxycodone or hydrocodone or morphine or Xanax or Adderall or any other controlled, potentially very dangerous. Well, that's not prescribed. Well, some patches, but that's not being prescribed a lot. But that's not the case.
It's not being prescribed, but they're not stopping it from coming across the border.
Yeah, I've got my own conspiracy theory there as well.
Well, here, let's do this. Do we want to get into conspiracy theories?
We'll probably have a whole episode on it.
We'll have a whole episode.
We'll have a whole episode on
Okay, well, let's give them a little teaser.
Right. That's what we just did.
No, I want to go teasing a little bit deeper.
I don't know if I get teasing.
Okay, let me think about this. Do you think that the government is trying to keep people addicted?
I think the government's solution to the drug product in the U.S. is to kill all the addicts by allowing enough fentanyl into the country to do that. That's my honest opinion. By preventing physicians such as myself from being able to prescribe medication by different things that are going on, which we'll get more into later too, the whole DOJ thing. By limiting access to the drug, the other thing too is they run the methadone clinics. So they're the ones making the money off the methadone, which is a horrible drug in my opinion, and trying maybe to push people back in that direction. So I think there are multiple motivations and ulterior reasons behind what's going on in the world of addiction treatment in our country. But again, that's more for the entire episode on conspiracy theories surrounding
Tune in, because that's going to be the bomb.
.com. And but yeah, also
you're so old, dude.
I am.
Speaking of old,
well, I had to finish asking the question, but we're also going to have some patients come in. We've had some interest in that, and we're going to have a place on our website where people can go and who listen to the podcast, if they have a question, could submit questions. But if they're interested in sharing their story, then they are more than welcome to join us and do that.
that'd be awesome.
And I've got some patients of mine who have already expressed an interest. I didn't ask anybody to do it. I didn't want to get involved in the whole.
I mean, tell them a little bit about confidentiality in that, because I wouldn't want anybody to think that if they come to your thing, they're going to be all over a podcast.
Unless they choose to be. But I just put a flyer up in the office saying, if anybody's interested, let me know. But there's patient confidentiality, which we're bound to. But then there's a whole separate piece of legislation called CR 42, or I'll have to look that one up before we actually go live.
Well, your doctor's supposed to know everything right off the top of your head, dude.
I can Google it real quick.
Google it.
But
Dr. Google.
you probably get 5 stars. I'm gonna get into that too.
Speaking about that, it's kind of hard to get 5 stars when you're dealing with drug addicts, right?
No, it's not.
It's not?
It's not hard at all. All you've got to do is give them 1,000 buprenorphine, 200 Xanax, and 900 Adderall at their visit. And you'll get 5 stars every time. And there are doctors.
And they'll say nice stuff about you, too.
Nice
so if you go out and you're checking a rating for something like your place.
I think sweet spots is around 3 stars. Because you're going to get the people with 1 star who didn't get what they wanted. And you got people with 5 stars who are actually coming regularly and doing well.
Yeah.
And so it'll average out to about 3 stars. So I think 3 stars is probably going to be the sweet spot.
Yeah. So would it be safe to say if you refuse to allow a person to continue doing drugs while they're taking, Suboxone, and that puts their life in danger if they continue to do drugs, and you take them off the Suboxone, they might get a little ticked and say something nasty about you?
Probably.
Probably.
Well, we try not to take anybody off of medication. What we do, though, is what's fortunately, hallelujah, after 3 and 4 years worth of waiting, there's a new injectable form of buprenorphine available. So that's what I've been tending to go more toward, both for the people who are uber stable and have done real well and want to just come in once a month and just get a shot rather than taking medication every day. But there's also a weekly version. So the people who are not doing so well, and I want to make sure they're taking their medication and not going and selling it and buying this other stuff. The shot has been a very good option for them. So I try not to stop medicine. I try to never give up on anybody, because I'm sure with these people, unfortunately, a lot of people in their lives have given up on them along the way, and they're probably very legitimate and good reasons for that having happened.
Yeah.
But I don't like to be one more person to have given up on somebody. So even if somebody disappears for 6 months and shows back up, I'm more than happy to see them again to try to get them back on track. Hopefully, at that point in time, they're ready.
Yeah. Hey, can you tell us a little bit, because you've got me doing some counseling for you, and I have to put a disclaimer on here. I do pastoral counseling.
Mhm.
I'm not a licensed professional counselor,
So we don't bill for it.
so we don't bill for it, right? And but you do have some licensed professional counselors that are the bomb. You've got two of them, and they're fantastic.
Yeah.
I think it's just two, correct?
Two others, yes.
Yeah, two others.
Mhm.
And tell them a little bit about your philosophy with the counseling and bringing these, medically assisted substance abuse treatment.
Counseling has been shown in multiple studies to be pretty much necessary to get to where you want to be in the battle with addiction. Because I tell people this on their first visit: the easiest thing you're going to do in this entire process is dissolve this pill or strip once or twice a day. The most difficult thing is going to be getting rid of the people, not going to the places, getting rid of the things out of your life, changing your lifestyle, learning how to cope with stress. Because we found that a lot of people just haven't learned how to deal with stress in their life and just haven't learned basic life skills a lot of times, because many of them grew up in households where addiction was prevalent and just weren't taught those things by the people who were supposed to teach them those things. So the counseling is, we try to gear it more in those directions, not just the pathophysiology of addiction, but actually how to start dealing when things come into your life, the things that you need to do and the steps that you need to take in order to get clean. So that's where the counseling is very important. We are also required once a month. We have 6 or 7 sessions per week, and I encourage people, especially starting out, to come at least weekly. And I mean, they can come to all 6 or 7 if they want to, if they feel like that would benefit them. And I do. It does seem that people who do the counseling and take it more seriously tend to do better overall in their recovery process. So it's definitely, and AA, NA have been shown to be very effective as far as also helping people get people off of their substance of choice in studies. So it's a very important aspect of the whole treatment regimen.
Yeah, yeah. I think that's awesome. I would just say that I find they need that sense of community, and I've seen it's. I've been blessed. I've been doing this with you now for providing that pastoral counseling for you for what, about 4 years, 5 years maybe, and it's been amazing to watch the life change. Look at the camera.
So occasionally,
occasionally. It's amazing to look at the life change. I mean, it's kind of really powerful. You see people that are just so frustrated and so fragile. And then you watch them start to develop life skills, coping skills. I spend a lot of time kind of working with emotional intelligence, kind of pumping that through, and you just see people, their whole level of professionalism comes up. Next thing you know, they become very career minded. Their energy focuses from getting up every morning and trying to find, $600 to go use. That energy focuses from getting up every morning and trying to build a career and a path, and it just becomes extremely powerful. It's been very fulfilling for me.
It can be
and
frustrating and fulfilling. But interesting you brought up community, because I have a question of the week that I always ask my patients. Change it every week. This past week, actually, it was what counseling topics have you found to be most beneficial or helpful? And honestly, 80% of the people, it wasn't necessarily even a topic. It was just hearing other people's stories. It was knowing I'm not alone. It was being able to express my concern. It's just the actual process of the counseling as much as the content necessarily.
I can honestly say,
to a community.
I think when I first started doing it, there was a whole lot of, let's talk about triggers. Let's talk about what's going on in your life. Let's talk about all this stuff. And I have found that a lot of times, I always try to bring it back to recovery. I always try to bring it back to patterns. I always try to bring it back to stuff. But a lot of times they just want to talk about general things that are going on in their life. life. And I'm like, dude, we need to talk about addiction here, right? And they're like, well, we just need this, right? And it's like, and a lot of times, we'll talk for, an hour, and I'm looking at and we're done, and I'm kind of like, hey guys, we're done. You want to go, you can go, right? And people will stay there and chat for another 15 to 20, 30 minutes, right? And they're like, we really look forward to this. And I think the key is, and it took me a long time to realize this, the key is that they need community, and they need to know that there's no shame.
Right.
It never ceases to amaze me. Somebody will walk in and they're really nervous, and they'll sit down and they'll go, well, I didn't get addicted like most people did. I'm not out here smoking crack and shooting up heroin. I'm not professional, and I've done a wonderful, and they're so afraid, and they're comparing themselves to everybody else. And then after a while, they start realizing that they're not the only professional person in the room that got addicted because some doctor prescribed medication, and they just couldn't get off from it. And when they start to realize that, the shame starts to fall off.
Right.
And unfortunately, I believe that society has put a shame on stuff. I can tell you, I think that when I first started this, I really had a difficult mindset. And I think I have the mindset that most people have when they look at this kind of stuff. I used to think, and I wasn't very effective in my ministry with people who were addicted. And I think it was because of my mindset. I used to think that people laid out of work because they were home doing drugs. And I used to think that people didn't contribute to society because they were all affected with drugs. What I found out is when they're doing drugs, they're going to work. When they're effective in society, they're going to work. But when they're not doing drugs, that's when they have to stay home sick.
Right. And
that becomes really problematic. It's called that dope sickness. Right. And when I started to realize that, it shifted everything. Right. And I started realizing that a lot of people look at, and I think a lot of people confuse what you do with Suboxone, buprenorphine, all of that stuff. They confuse that with the methadone clinics. Right. You want to speak to that a little bit?
Yeah, I'll touch on both subjects, both the addiction being a disease versus a choice, and the whole methadone thing. Let's go get into receptors a little bit and all that, but it's a good thing to cover. So, is addiction a choice, a moral character weakness, a lack of willpower, or is it a disease? It's a disease. Twin studies have shown that. Adoption studies have shown that, where they've split up twins, put one in one type of household, one in one type of household, and it came back to genetics, what were their parents like. Adoption studies, same kind of thing. Have all shown that this is a disease. There is a choice component too, though. People say, oh, we can choose not to start. You can if you're the most naive individual that I know. Every child who ends up graduating from high school has been exposed, I'm sure, to a plethora of chemicals that they have tried. Some people, it rolls right off the back. I, thank you, have 14 screws and a 14-inch plate.
Wasn't my fault.
Story for another day.
I volunteered to go first.
Okay. Story for another day. So I have an X-ray of my leg that if I wanted to, I could walk in any doctor's office all around and get a prescription for pretty much whatever I wanted to. But I was given a handful of Percocet after my surgery. I took them a couple of times. Didn't particularly feel anything other than it did help some of the pain. After 4 or 5 doses, I stopped and moved on to my ibuprofen, and everything has gone well, and the leg's doing great. But there are some people who take that first Percocet or take that first drink of alcohol, and it's a genetic predisposition that you have as to whether you're that person. Some people on the alcohol can drink on New Year's and not drink again until the next 2 years. Some people, once they have that first drink, it's over. they are hooked, and they are going to continue to use that because they like the way it feels. The dopamine in their brain gets released by the song we're going to sing, or sang earlier, or what have you. And therefore, that feels really, really good to them, and they want that feeling over and over again. And they will do what it takes to get that feeling over and over and over again. So they will continue using that thing. And I believe everybody's got their thing, but it is absolutely not the same for each person. Some people it is opioids. Some people it's alcohol. Some people it's gambling. And I could easily fit into that category. I dig it like this when I get over on the roulette table. So I have to watch myself, or I get in trouble. Some people it's methamphetamine. It's just different. It's different things for different people. Some people it's another person, and we'll get into that. I'll probably give a whole episode just to that, just because that works out being such a bad relationship. If it's somebody that you're romantically interested in, it ends up being an addictive relationship, which is usually a lot of times will end you up on Dateline or one of those crime shows.
Let's hope not.
Yeah. Or if your kids go there. I mean, especially women put their kids there, which turns out to be one of those households where the kids rule the household, because that's what the...
So you're saying people get addicted to their kids?
Yeah. I mean,
yeah.
So when the kids move out, then they are completely...
They're lost. Yeah. Can I add one to that?
Mm-hmm.
I think people are addicted to certain emotions.
Okay.
I think people can get addicted to anger. I think people can get addicted to depression.
Mm-hmm.
I think people can get addicted. And that's not saying that clinical depression. I'm not trying to.
I think there are adrenaline junkies out there who get addicted.
They're addicted to adrenaline, right? And how they get that adrenaline might be different. Mm-hmm. And once they get addicted to it, because anytime the amygdala decides to override the upper part of the brain, the reasoning, it triggers adrenaline. And I think people get addicted to that adrenaline, and therefore they choose to override the rational part of their brain and put themselves in traumatic situations subconsciously.
So where the choice comes in is, fortunately, there's good treatment, at least on the opioid side. On the others, less so, but there is very good treatment, which fortunately opioid is the vast majority of the addiction that's going on out there. The heroin being replaced by the fentanyl and the other opiates in the form of buprenorphine. So touching a little bit on that, so let's go with an opioid molecule. When you ingest an opioid molecule, however you choose to ingest it, snorting, whatever, it gets into your bloodstream, goes to your brain, and there are millions of little receptors in your brain where it works. They're called mood receptors, opioid receptors, whatever you'd like to call them. And they're there for a reason. Our body actually makes opioids. They're called endorphins and enkephalins. So when we exercise or something good happens to us, they get released. They come along, they hit that receptor, they push it down to here, and we feel good. The pills push it down to here, and the injectables push it down to the floor once they hit that receptor. Those receptors were perfectly fine being empty till you start using opioids on a regular basis. But now when they get empty, they're not happy. And they start yelling and screaming at you saying, feed me, feed me, feed me. I'll make you ache, shake, sweat, diarrhea. Think about nothing but me till you feed me. So you feed it. Feel bad for a while, and then it comes off, and it gets to the point where you're using just not to feel bad rather than get a whole lot out of it. The way the buprenorphine works, Suboxone, Subutex, Zubsolv, Bunavail, just different ones out there, the injections, Brixadi, they all work by coming along, hitting the receptor, and just sitting there. Maybe pushes it down back like our natural ones. They're called partial agonists, so they do stimulate a little bit. But mostly they just sit there. So the receptor's happy. It's not yelling and screaming at you, which they should take so you're not sick, so you can take care of the house, the car, the job, the kids, like you said, you go to work and do the things that you need to do in life. And there are two caveats with that. So if you're taking the buprenorphine regularly, you do something else, you're wasting your time and your money, because the receptors love the buprenorphine. It's like chocolate cake and everything else is like broccoli or Brussels sprouts. We won't let go of this and go grab that. Second caveat, though, is for those of you out there who may have tried the buprenorphine a couple hours after taking some fentanyl, and it made you sick. And yes, it did, because it came along and it knocked the fentanyl off the receptors. The nerves went from being stimulated from down here to up here, and it kicked you into withdrawal. timing, which is why it's best to be done in a medical setting or in a medical supervision at least, kind of getting switched over. Plus, it's a lot cheaper. I mean, it's amazing people tell me how much they spend monthly on getting buprenorphine off the street, as opposed to just going to the physician. It literally is maybe 20% of the costs doing it the right way. Going to the physician, getting the prescription, going to the pharmacy, if you can find a pharmacy to fill it, getting it filled, and taking it like you're supposed to. So that's where the choice comes in. There fortunately is a very good treatment out there for at least opioid addiction.
Yeah.
So now methadone. I said, all these things, push it down like this and that and everything. Methadone is a full agonist. In other words, when it hits that receptor, it pushes it down just as much as the heroin does, just as much as the oxycodone does, just as much as all the others do. It is a full opioid. The reason they think it helped addiction is because it's so long acting. So you didn't get that immediate up and immediate down, because part of that, that's why it's delivered in different ways. That's why if you take a pill, it's a lot less addictive than if you snort it. Because of how quickly it gets into your bloodstream. So they think, since methadone is much slower in and out, then it's going to be less addictive. And it may be less addictive, but it's one of the more dangerous. It counts for a small percent of the prescriptions out there for opiates, but it's like 5 times more likely to cause somebody to die from an overdose. So it's dangerous. You're supposed to do EKGs on people every year. And it's, again, a full agonist. Everything that ticks me off, though.
Hey, do me a favor. Explain the word full agonist.
Full agonist means when it hits that receptor, it pushes it down all the way, not just part of the way.
Okay.
Basically, when it stimulates, so again, the buprenorphine, when it hits the receptor, there's probably a little stimulation, but like our natural ones do, the endorphins and caplins. So that's, again, but when the methadone, oxycodone, heroin all hit that receptor, they fully release the floodgates and let all those little chemicals out into your brain that make you feel good. Okay.
Can I interrupt at this point and ask a question, or do you still have something you want
I'll
to
go just touch on methadone. And then,
okay. Yeah.
What my pet peeve. My pet peeve is when somebody comes in and either they themselves or they say a family member said, well, you're just trading one thing for another.
That's the question I was going to ask.
Yeah. And I always pull out my little analogy. Let's see if I got something I can do that with here. Yeah, here we go. I'll use this. All right, put your hand out.
Me?
Yeah. All right, this is an opiate. The touch receptors on the back of your hand are the opioid receptors in your brain. So that's what an opiate does when it hits your receptors. You feel that going to your brain. Your brain is sensing the sensation of me tapping on, me stimulating those receptors. This is buprenorphine. Is that the same thing?
No.
It's not the same thing. In fact, now if I came along, you don't feel that, do you? It's blocked. So that's the analogy I like to make, is not the same thing.
Not the same thing.
Not the same thing at all. Now you're not trading one thing for another. You're not giving people going out selling everything their own, including their bodies, to get buprenorphine off the street, unless they've got to the point where they've gotten addicted to everything else, and that's all they can find. But no, it's not the same thing at all. Never will be. But unfortunately, I've got two patients right now who have loved ones who are giving them a hard time about being on the medication.
And you get a bad rap of being the kind of like the drug doctor, because you're dealing with people who have addictions, and then you've got this stigma that doesn't understand it, and they associate it with methadone, and they don't see what's going on. And I'll be honest with you, after spending the time with you and going through this and seeing the difference in these clients, I love these clients. I have fallen in love with these people. They are awesome people. And it just, I care very deeply about it. And they come in and they're broken because their families and the community is telling them that they're just trading one drug for another, and they feel like they're just being abused. And, when people tell them, hey, if you want to quit, you just need to quit, right? And you know what? I think, and you correct me if I'm wrong here, but I think that's good advice. for some people.
Mm-hmm.
I think some people can just quit cold turkey.
Those are the people, I think, who don't have the genetic predisposition. Those are people who are just doing it to do it because they like it and they like to do it from time to time. It's not the people who truly have the addictive substance use disorder. Basically, those are people who are just doing it because, hey, I want to feel a little high right now. Let me go do something. But those people absolutely can stop anytime they want.
Yeah,
without assistance, probably.
And I praise the places that are out there. You might be listening to this podcast, and you might be a part of a clinic or something. Not a clinic, but a place where people go and they go cold turkey, and you help them work through that. I praise what they're doing. I think that is phenomenal. If a person can quit that way, by all means, that's the path to take.
Right.
What I find is that some people have tried that numerous times.
What I like to say is that people who have actually substance use disorder, I relate it to diabetes just because I can draw so many analogies between those two diseases. And in this one, there are diabetics out there who, if they just eat right and lose some weight and everything goes well, then they can get their sugars probably under pretty good control. However, there are others where they just have the genetic predisposition to it. They have the disease, where not only do they have to eat right, which they do have to do, that's the lifestyle, and I throw that out with a lot of my patients too. It's not just about taking the medication, it's about the lifestyle, changing what you're doing and who you're around and all of that. But you have to also take the medication because you can eat what you want and take the medication, your sugar's going to be 500 if you're diabetic. You can take the medication and eat whatever you want, and your sugar's going to be 500. So you got to do both to get that disease state under control. And if you don't, then unfortunately things aren't going to go well, and you're going to end up with complications from your disease. Again, there's so many nice analogies between those two that I like to draw out. But
you're saying something that really triggers me to ask a question. And this is a question. This isn't a leading question. I'm interested. What you're saying is there's a difference between doing drugs and having a substance use disorder.
Yes. Doing drugs, anybody can do drugs. You and I can go out and do whatever we want to after this and do it one time and say, oh, that was interesting, and never do it again. Or we could say, okay, let's get together once every month and get together, and every time we get together once a month, we do something. That's doing drugs. Substance use disorder is a medical condition, and there's a definition for it, which I'm going to go by through word for word, probably in the first episode. And actually, this
might be our first episode. I'm liking this conversation.
Well, maybe our second episode. And actually go through it word for word and define what the characteristics of it and what kind of like if you want to be diabetic, you have to have fasting blood sugar above 125 or regular blood sugar, blah 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 blah. You have to have it has diagnostic guidelines. Just like this has a diagnostic guideline that in substance use disorder, it has to be compulsive. It's something you have to want to do over and over again, despite negative consequences. It's a chronic disease state, prone to relapsing and remitting. So there are defined a definition for it put out by the American Society of Addiction Medicine that they're the gurus in addiction. They've been around for a good while, and they're the ones who pretty much have all the educational material on addiction, doing the research on addiction.
So it would be safe to say then that somebody might be a chronic user, right, and not have substance use disorder.
Right.
That's profound.
Yeah.
That's totally profound.
Right.
And it would also be safe to say that
if they go out there once a month, get together with their buddies, do this, do that, and it doesn't impact their life in a negative way, it's not something that they're thinking about all day, or they're looking forward to that whole 29 other days of the month and that kind of thing. They don't have substance use.
But that's not on the same the same plane as that. That's not a reason to go and say, hey, I don't have substance use disorder, so let's go out and party, right? That's not an encouragement to go out and use illegal drugs.
Oh, absolutely not.
Yeah.
You'd be the one actually probably being the occasional user that would actually get caught and end up in jail, as opposed to the habitual user who's learned the ways around things and how and who and what and when and where and all that stuff. Yeah, you
So
probably
there's
much more likely
repercussions to that. I
oh,
mean, I
I mean,
think
you do
there's
anything illegal, there's repercussions.
anything illegal, there's
It's
repercussions.
legal for a reason. I mean, it does have detrimental effects on your body. Even the occasional use has detrimental effects on your body.
So there's that leads me to another interesting question. Incarcerated individuals that are there for drug use,
Mhm.
for habitual drug use, a lot of those might not have substance use disorders. They might have behavioral
Right.
issues. And it takes a physician to diagnose that, correct? And to me, that's something interesting that the public needs to wrap their brain around, because you can't just diagnose your kid who's out partying
Right.
as having substance use disorder. He just might be a little smart butt that needs needs a little direction in his
Parenting
life.
is life.
There's a difference between the two.
Yeah.
And you might have a kid that has substance use disorder, and you might be trying to treat that like, hey, I'm just going to have to jerk a knot in his head.
Right.
Right? And that makes the dynamics, or the family dynamics, very, very intricate, you know?
Because it's genetic. So a lot of times, if the kid actually does have substance use disorder, the parents probably have it. If the kid doesn't have it, he's just out whatever, then the parents don't have it, it's going to make them a lot less, I won't say understanding, but a lot less likely to emotionally feel what, I mean, like somebody who does have a history with substance use.
So would you say that there are genetic, and I'm going to borrow a phrase that's used in religiosity to some degree, would it be fair to say that there are genetic generational curses and behavioral generational curses, and the two are different? Does that even make sense? Does the question even make sense?
I have to give some thought to that, but I mean, on the surface, I'd say probably yes, but because right now availability, opioids, you can probably get at every gas station if you wanted to. I've got a patient who goes to a vape shop up in a local city and gets his cocaine every week. I ask him, where are you getting this?
Yeah, don't tell them where to go.
And he said, oh, from the vape shop. But you have to know a guy. So, it's crazy. But just the availability right now with the like I said, drugs just walking literally into our country, um, and every day in large amounts. So yeah, um, and that changes, I guess, with the technology and the way the society is at the time. But absolutely,
Well, Dr. Troyer, I think this first episode has been really awesome, and I think we're just touching base on a lot of stuff that will show you that this little podcast is going to be something worth
it's gonna
listening
be
to.
awesome.
It's going to be awesome.
But anyway, but each episode I am going to have something called Update of the Week,
Sure.
which I guess if this is the inaugural one, I'll go ahead and throw it out there now. Basically based on double base there. On what I'm seeing with the drug screen results with my patients, and had a surprise a couple of weeks ago. Um, Something that hadn't shown up for over 4 years. Yeah, the meth is still there, the coke's still there. Track is increasing, being mixed in with fentanyl probably, although some people may be getting it separately, but probably about 20-25% of the fentanyl positives I'm seeing are associated also with track. Um, Ecstasy.
Is ecstasy
About
coming
4 years?
around?
No, after about 4 years of nothing. So I'm sure the insurance companies, why are you still testing for it? This is why. Because things come back. So ecstasy, back. Person ended up in the hospital. So if you are, it may never have gone away. I mean, that we're in a little corner here in North Carolina, our drug supply. That's actually my question of the week this coming week is I'm going to try to nail down on how the supply is getting to my patients. So I'm assuming it comes through Charlotte, um, but at least in this area, nothing for 4 years, and then all of a sudden, boom, ecstasy, person in the hospital. So, gotta be careful out there. You just don't know what you're getting. I surprise one or two people every week by what's in their drugstore. Um, no way, I didn't do that. I didn't do that. I show them the number. Show them the case this camera. Um, show them the number. Here it is. And they had no idea that they were. In fact, what was it? This last year, sometime 4 people died in our county, just smoking a joint because they'd been laced with fentanyl.
Oh my gosh.
4 people died.
This is a to me this is a ministry that a
Yeah.
lot of people overlook. A lot of people don't see. It's like they're the forgotten people. They're kind of like we treat them like they're the dregs of
Absolutely.
society, but
Yeah.
they are not
And that's
dregs
not
of
that's the
society.
first thing that has to go away. I mean, if a child abuser can look down on somebody doing drugs, then we got a problem. But everybody thinks the other person's thing is worse than what they do. I mean, even
I know.
the people who are opiates come in addicted to them. I ask them about alcohol. Oh no, I'm not an alcoholic. So everybody thinks the other person
I think there's a hierarchy of drug users. I mean, it's kind of like I smoke weed. I'm not that bad, right? And then there's the other one where it's kind of like, but at least I'm not, at least I'm not doing pills. And then the pills people are like, at least I'm not doing meth. And then the other ones, then the bottom is at least I'm not smoking crack. you know?
Rationalizations, those 4 words. At least I'm not. You can
At least
rationalize
I'm not.
anything that you ever want to do in your life that's harmful to your body and to your soul and to your spirit by just using those 4 words. At least I'm not.
You know
Be
what I,
careful of those
you know what
four
I found
words.
another phrase that's used a lot,
Mhm.
and I'm going to say it politely, is people will get to the point where they're doing really well, and then right before they relapse,
Mhm.
every single time, right before they relapse, it's like they get to the cliff, and right before they relapse, the last thing they say before they jump off the cliff is "screw it."
Mhm.
Right? It's like the Geronimo of jumping off the cliff into relapse. And we spend a lot of time in counseling talking about that Geronimo
Yeah.
moment,
Yeah.
because it's in that Geronimo moment that your choice to override the free will that you got from getting in the program that you got back, your choice to override it becomes a choice at that moment.
Yeah.
At
And you're,
that
and, you're,
moment,
and you're not screwing it, you're screwing yourself.
yourself. There's
So,
so much truth to that. Okay, so as I said earlier, this is our first episode, and we're trying to kind of set up what we're doing. I think we went a little longer than we intended to,
yeah.
so don't if you guys have been listening to this, we probably won't go this long in the future. But I think we're just excited about setting this up. And
And we got to sing our
Eric
songs.
Eric wants to sing a song, and I
Not,
strongly
not today.
recommended
Not today.
to him not to do it. But he insists that we sing this song.
Next episode.
No, let's do it now.
We don't know the words yet.
Oh,
We got, we got,
I got to learn the
we
words.
got to get the time
Okay,
down.
all
We
right.
gotta get the time.
So tune back in. I'm going to say something's going to make me look old. Same bat time, same bat place, same bat channel.
That's it.
Right? If you've never heard that, you're a puppy.
And you probably won't get the song.
You probably won't get the song. But Eric, you want to say anything before we part?
Thank you for your time. I appreciate it. And again, we didn't do so much today, although we did touch on it some. If you're a family member or a loved one of someone who is addicted, that's tough. It's
Yeah.
very, very tough. And you're going through a lot and you don't understand why this person isn't the person they used to be and why they just can't stop. We're going to try to help you work through that, get through that. Going to try to, I mean, if there is, sometimes there just isn't. Do what you can do to help that loved one get help, get clean, and do the things that, be the person they used to be. Because, I mean, I have so many patients, come in and say, as far as even taking the medication, I feel like my old self. It can happen. So just don't give up, and hang in there with us. Um, and I look forward to having more sessions with you in the future.
One last thing.
Yes, sir.
Could you tell them how to get a hold of you, how to get a hold of Troyer Medical?
Troy Medical, I think it's troymed.com now or troymedical.org, but our office number is 704-855-2101. That's usually the best way to do it is just call. We actually have people answer the phone. So
Okay. So let's do this, guys. We can
get the story there. Let's do it. Let's do this. We're not trying to knock off on Nike or anything like that. I made a movie, 2010, with Meatloaf and some other actors, Ed Prong and Ed Asner even. And before we started each scene, my assistant director, a little Italian guy, Joe, would get everybody in place, and he said, "Okay, let's do this," in his little Italian accent, and that's how we got things rolling and how things started moving productively forward. So that's kind of going to be our driving theme for this podcast is let's do this.
Let's do this.
Let's do this.
See you next week.
Yes.